Okay, welcome back. I'm Andrew Penn. I'm an associate clinical professor in the UCSF School of Nursing and a psychiatric nurse practitioner. This is part two of the Introduction to Psychopharmacology, first lecture, part one. And we're going to talk now about the process of using a medication and the sort of course of typical treatment. So I like to think about medication treatment as having three hurdles. The first hurdle is tolerability. And by this I mean, can they actually tolerate taking the medication? This is not a question of if the medication is effective. This is a question of can they actually tolerate it? And this is determined by side effects. So, for example, if every time somebody takes a medication that you prescribe, they throw up, that's not going to be an effective medication. Fortunately, we usually know the answer to this question pretty early on, usually within the first couple of weeks. Now, it's important with a lot of medications to educate our patients that these early side effects are transient and short-lived. So that means that they're going to go away pretty quickly if they can just get through them. The problem is, particularly with a medication class such as SSRIs, the side effects show up well before the benefit. So many people, if they're not educated about this, they will quit the medication well before they ever have a chance for it to work. But what they will remember is that that medication didn't work for me, when the truth of it is that medication was intolerable for them. So these are things like GI distress, headaches, and insomnia. The next hurdle is what's often referred to as response. And response means, are you starting to show some benefit from the medication? Now, this, depending on what we're treating, can take several weeks. Usually, I tell people to expect some response if we're talking about an SSRI in the first 2 or 3 weeks. But a lot of times, that's not going to be a full response for until they've been on it for usually 4 to 6 weeks is considered a reasonable amount of time. Now, this is where you're going to start to see some of the later onset side effects. It kind of depends on which medication we're talking about. But since I've been using the example of SSRIs, so things such as sexual dysfunction, fatigue, or weight gain can be common later onset side effects. But so at this point, with response, this is often when you're going to see a patient for follow-up. And the question at this point, so is assuming that they have tolerated it, or the things that are intolerable, are they willing to put up with it? Are they showing some response? And this is when you're going to start thinking about possibly adjusting the medication dose, typically in an upward fashion, because what we're looking for is our last hurdle, which is remission. And we always want to make remission our goal. So the idea is, don't just make somebody a little bit better if you can make them well. And this can often take quite a bit more time than getting a response, and often will require adjustment to the dose or augmentation, etc. And this is also where you see later side effects. Now, it depends on the medication. Fortunately, the SSRIs don't typically have long-term side effects, but let's take a medication like lithium, for example. Lithium can have issues of kidney impairment or thyroid impairment many years after starting it. So, 10, 15, 20 years after starting it, you can see some impact on the thyroid or the kidneys. And we'll talk more about that when we get to the bipolar content, but you can have side effects that show up well after a medication has been started. Now, I don't have any evidence to support this claim, but this just comes from my own clinical practice of many years, that generally if you make your patients fat, impotent, or sleepy, they're going to quit your meds. And typically what happens is we then label them as quote unquote non-compliant, when really they're acting in their own best interest. So really, I think weight gain, sexual dysfunction, and sedation at night, during the day and not at night, are really problematic for most people, because again, it goes back to that issue of impacting function. And our goal here is to improve function, not to impair it. So it shouldn't be a surprise to us that when we cause these side effects, we often lose the patient's interest in taking that medication and they stop taking it. Now, this is kind of a broad outline for the treatment of depression and anxiety. So typically we'll talk much more about this in greater detail in the depression and anxiety talks, but just to kind of give you the view from 30,000 feet, one of your main workhorses is going to be an SSRI. Now, these are going to help typically after 3 to 6 weeks of taking them. So you may need to use an adjunctive medication such as a benzodiazepine for the treatment of anxiety. But as I'm going to talk about in the anxiety talks later on, I want you to think about benzodiazepines as short-term medications and not as ongoing medications ideally. You might also want to help the person improve their sleep. So a hypnotic such as trazodone could be very helpful for improving their insomnia while we're waiting for the workhorse medication like an SSRI to really get to work. Because once that begins to work, we often get improvement in sleep as well. So then you're going to see the person back, say maybe 4 or 5 weeks later. We're going to ask them, are they still taking it? Because that is a question, that's a probe around tolerability. Assuming that they are, we want to see, are they well? If they're not well, they're only partially better, we want to think about increasing the dose until we get them well, or we hit a point where we can't go any further because they either can't tolerate the side effects or there's some issue of safety that emerges at a higher dose. So for example, bupropion or Wellbutrin has a ceiling dose of 450 milligrams. We can't go higher than that safely because we start to risk seizures. So we might push that dose up to 450, but we're not going to cross that threshold with that particular medication. Now, if they stop the medication because it's not working for them, or they just say, I really don't like this medication, we're going to think about switching, and then we kind of go back to square one. Once we've gotten them into hopefully a place of remission, we're going to then look for any residual symptoms. So we want to try and target those. So for some people, for example, their mood may improve well before their sleep does. So we might need to use a sleeping medication like trazodone to help their sleep, even though their depression is largely improved. And then we need to talk about how long should you expect to be on this medication? Because if we don't have that conversation, one of two assumptions will usually get made by the patient. The first assumption is they should stop taking the medication as soon as they run out of it, like you might with an antibiotic. Now, we might laugh at that because it seems so obvious that they shouldn't, but unless we're telling patients that they shouldn't, that they should continue it, they may assume that they're supposed to stop at the end of the prescription of medication. Or the thought they may have is, oh no, I'm going to be on this for the rest of my life. And the reality is many people are not on medications for the rest of their life. So in the case of depression, we might talk about, okay, this is your first episode of depression. I really want to make sure you continue to stay well for at least, I would say, let's say a year. And so let's plan on this time next year revisiting this question of whether or not you want to continue to be on this medication, or do we want to try taking you off of it and seeing if the symptoms come back or if they stay away. Yeah, especially if it's more of a situational kind of depression where perhaps their life circumstances have improved in that year. If somebody has a history of ongoing chronic psychiatric illness, then we need to have a conversation about, it might be beneficial for you just to stay on this medication because it seems like the times that you've been off of it, the symptoms have returned. But that, again, is a slow process of negotiation because, to go to see a psychiatric provider and be told that you have to take medication for the rest of your life after the first visit with that provider, I've heard likened to going on a first date, and before the date is over, you've decided to get married, have children, and be together for the rest of your life. It generally doesn't go down that way. So what about bipolar disorder? So bipolar disorder is a little different than unipolar depression because what we're trying to do, we really need to think about bipolar disorder as more of a episodic chronic illness uh, that has varying needs for medication treatment. So when somebody has an acute episode, and when we talk about episodes in bipolar disorder, we're talking about depression or mania. So when somebody is in one of those episodes, they're often going to need more medication than when they are euthymic or at baseline. So euthymia is just a fancy word for normal mood state. And this is tricky because a lot of times people are put on these additional medications when they're quite ill, or say, for example, when they're in the hospital and they come out of the hospital. And I used to work in an intensive outpatient program for a long time. So I would receive these people that maybe had been in the hospital for 2 weeks with a very intense manic episode. And they came out on a lot of medication, maybe 3 mood stabilizers, a couple of antipsychotics, and some sleep medication. Um, pretty complex pharmacology. And so then and usually with a lot of side effects. So then I'm faced with the challenge of, well, we just spent 2 weeks in the hospital. They clearly needed this much medication to get stable, but do they need to stay on it? Because if I do that, if I take them off of it too quickly, I run the risk of destabilizing them. If I keep them on it too long, then I run the risk of non-adherence because eventually patients will get frustrated and make their own decisions. So our challenge is to work with people and to titrate these very carefully but thoughtfully in a way that minimizes the amount of side effects while maintaining the mood stability. But in general, most people with bipolar illness need some level of mood stabilizer even when they are well. They may not need as much as they're taking uh, when they're more symptomatic. What about psychosis? Typically, we're using an atypical antipsychotic these days. And your first question is, can they tolerate it? If they can tolerate it, then you're going to adjust the dose until you start to see a response, and hopefully you see some degree of remission. Remission isn't always entirely possible with psychosis, but it does happen sometimes. And obviously, if it's not tolerable for them or it's not working for them, you're going to change it. If you're getting some benefit, but you're having residual symptoms, you might think about augmentation. And Chelsea Landelin will talk more about this in her antipsychotic talk. And you might think about something like clozapine if somebody has a very refractory case of psychosis. If the person is doing well and you don't need to adjust the medication, then you need to talk about setting the expectations for that drug. So for many people with a psychotic disorder such as schizophrenia, it tends to be a chronic disease. And so we need to have a conversation about taking medication in order to stay well. And increasingly, I've been using more long-acting injectables because that makes it a lot easier to remain adherent to a medication regimen if it only has to be delivered once a month or sometimes even once every 2 or 3 months. So those can be helpful in that situation as well. So here are some of my pearls for psychopharmacology. So first of all is that even though this is a psychopharmacology class, not every problem requires a prescription. So I'll talk about in a minute. There's many things that we can't treat with medications, and we need to be realistic about what we can and what we can't treat. Now, I want to caution you against undertreatment because sometimes we're excessively timid in our work, and we do patients a disservice when we do that. Because to leave somebody limping along when they could actually be much more well, forgive that grammar, they could be better, uh, then why not? I'll often have this conversation with patients where I say, if you're going to be taking medication, why don't we make sure you're taking enough to get the job done? Now, I don't want you taking more medication than you need to. Believe me, I'm going to be really cautious about that. But, if you have a headache and 2 aspirin will help, why would you take half? So sometimes I see people come referred to me from other clinicians where it was decided that a medication wasn't effective, when really, in reality, it was just underdosed. So the take home here is to be appropriately cautious but not timid. Now, when you're in a crisis situation, say you're working in psych emergency, you're going to use the most effective medication that you have, even if it's not terribly tolerable, because hopefully you're only going to be using it for a very short period of time. But if it's not an emergency, then you have more latitude, you have more options. So in that case, you're going to use the more tolerable medication, even if maybe it's not the most effective medication, because the person is more likely to stick with it if it's tolerable. But the reality is, anybody who tells you this medication has no side effects is probably telling you a lie. Maybe not intentionally, but the reality is that if we're going to treat people with medications, that in order to get some benefit, we generally have some side effects. Those side effects may be mild, but there are always side effects to contend with, and that's sort of the cost of doing business. Now, but That said, tolerability is really important because if somebody won't or can't take the medication you're prescribing them, it certainly can't help them. So it does no good if it just stays in their medicine cabinet. Now, a lot of times, when I was first in practice, I really felt like if a patient left my office after an intake and opted against taking medications, I felt like I had done something wrong. I felt like I had failed somehow. And the reality is that patients get to make the decision about what they want to do. And your job is to provide them with a list of options. Sometimes I think of it as a menu. Sometimes patients will come in and they'll kind of preempt you and they'll say, I'm not sure I even want to take medication, right as they're sitting down in your office. And I would say to them in that situation, we just met. I don't even know if you need medication, but tell you what, why don't you tell me why you came in here? What you're concerned about, and I'll listen, and I'll probably have some questions for you, and then I'll ask you if you're interested in talking about options. And if you are, I'll have a menu, and one of the things on that menu I can assure you will be that you don't need to do anything differently. But I'll probably have some other ideas on there as well, and then you can make the choice. Does that sound okay? Most people are okay with that. And, sometimes people will ask me, well, what should I feel like when I'm taking this medication? And what I tell them is that, this isn't going to make you high. This isn't going to make you feel better than well. This should make you feel normal. So when somebody comes into me and says, ever since I started taking drug X, boy, I really feel more like myself again. And, my partner notices that like I'm my old self and um, you know, I've had people come in and tell me, my spouse told me that she heard me laughing when we were watching a movie yesterday, and she hadn't heard me laugh in 6 months. That's how I know we're getting somewhere. Okay, so medications really, the intention of medication is to restore normalcy. Now, the problem when we're psychopharmacologists is that we're holding these hammers called medications. And when we have medication hammers, all problems start to look like nails. And that's a problem because there are certain things that we can treat with medications. So always would say in practice that medications change symptoms, they don't change circumstances. So things that we can sometimes change are things like sleep, mood, anxiety, psychosis, agitation, their energy level stability in something like bipolar disorder, their attention and focus, and sometimes we can influence their substance abuse. But there's a large list of things that we can't change with medications. Medications don't fix relationships, they don't fix lousy jobs. They're not terribly effective in the treatment of personality disorders. They certainly are not very helpful in grief. You should never medicate somebody because you're pissed off with them or because you feel very sweet towards them. That's countertransference, and that's a risky place to find yourself in. We don't want to be making up for the shortcomings of a healthcare delivery system uh, with our medications. If somebody really needs more interpersonal therapy and we're being asked to give them medication instead, frankly, that's inappropriate. But you're going to see a lot of that, especially as our healthcare system becomes increasingly stressed with mental health concerns. A lot of times you're going to get calls from non-prescribing colleagues who say, I don't know what to do. You've got to do something about this patient's medications. And I'll say, okay, hold on. Tell me what's going on. And if it becomes clear that what's happening is really much more interpersonal or circumstantial, I'll I'll tell that colleague, here's the problem. I'm not sure where there's a medicatable target here. We could certainly help this person sleep. I can take a look at their antidepressant if their mood is getting worse, but I can't change what's happening at home with the medications, for example. Larger systems issues such as social injustice or homelessness or incarceration are also inappropriate targets for medication. Um, and, there's medication is a poor substitute for taking good care of ourselves. So, a lot of times what our patients also need, I'm being cautious not to say need instead of medications, is that they need to be eating better. They need to exercise more. They need to be interacting with other people. But a lot of times they're not. And so when we're having those conversations with patients, we need to be thinking about bigger picture of wellness. And then lastly, I put this in partially as a joke, but the old French word ennui. This is that sort of sense of inner restlessness and not sure if we're doing the right thing. I think we've all had that experience as a human being, but it's not really a good target for medication. So, the take home here is that not every problem we face requires a prescription. I made this a few years ago. This is just for fun. But if should there be a prescription drug for ennui, and it was called ennui, this might be the marketing for it. I'll let you look at this at your own time. So let's talk about the actual nuts and bolts of ordering medication. Now, most of you are going to be working in systems where you have a electronic health record. And so that means that your medications are going to be ordered on the computer. So what that's going to look like is probably a screen that looks like this. And there's some good habits I want you to be in. I always want you to ask about allergies. Don't just rely on the chart. Make sure you ask and confirm that the chart is correct. Old meds, get rid of them. Get them off your med list. Because if your patient should end up in the ER between your visits, you don't want the ER doc thinking that they're taking 9 different antidepressants because your med list is a list of all the things that didn't work. So discontinue old medications. Be in the habit of checking for drug interactions. Many EHRs will start to do this for you, but don't get lazy. Make sure you do that yourself. And you always want to think about before you add more medication to the mix, think about optimizing the things that the person is already taking. So in this particular screenshot here, we've got the drug, which is clindamycin, obviously not a psych med. You have the dose, which is 150 milligrams. You have the route, which is PO or oral, and the frequency, which is 3 times a day. You'll see this term SIG, which stands for signifier, it's Latin, which is essentially the instructions of how to take the medication. This is what will be on the label of the med. So this might be like one cap PO TID times 5/D, which would be, that's shorthand for the 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 write-up that's on the screen here. And then you want to put your refills in there, and you want to use your clinical judgment about the refills. We'll talk about that in a second. But again, this goes back to the old, what used to be 5 rights, but now is 7, I think. So right patient, right drug, right route, right dose, right time, right reason, and right response to the drug. And it's really easy when you're having a busy day in the clinic and you're treating, you're going to see 9 different people that day. If you're not careful, you can put the wrong orders in the wrong chart. So you really want to make sure that you're looking at the right chart before you put the orders in, and that all your ducks are in a row before you hit that sign button, because that is attached to you and you are liable for that. So be thoughtful and careful. Take an extra beat and make sure you've done everything right before you hit the accept and send button. So some of you may never get the opportunity to do this, but we should try this out. So I've put on CLE a blank prescription form that you can fill out. So you can practice writing a good old-fashioned paper prescription. And this is all the shorthand for those of you who really learn nursing in a computerized world. That's great, but you may still see these paper prescriptions. And in a lot of systems, particularly for Schedule II drugs, such as which in psychiatry is going to be your stimulant drugs, they still need to be written on paper. There are some systems, such as Kaiser, that do have a DEA approved electronic prescribing capacity, but for the most part, you still have to write these out on paper. These are what used to be called triplicate prescriptions. The reason why they were called triplicates is because the patient got one, you were supposed to hold on to one as a practitioner, and the pharmacy would send a copy to the State Department of Justice. And that is what can be searched now via the Cures database, which is administered by the California State Department of Justice. It's a prescription drug monitoring program, and once you're licensed, you'll need to get credentialed so you can log onto there, which allows you to make sure that your patients aren't getting medications from multiple providers. Now, with refills, you cannot put refills on Schedule 2. For Schedules 3 through 5, sorry, 3 through 4, you can put up to 5 refills. Now, you don't have to put 5 refills on, and you want to use your clinical judgment about that. You can't post-date prescriptions, but you can write "do not fill until." So sometimes in places where you can't put refills on a prescription, such as for Schedule 2 prescriptions for psychostimulants, somebody may provide the patient with 3 prescriptions that are all dated on the date of the visit, but with the notation of "do not fill until." And that may be a way that you can help your patients not have to come in and see you every month for their prescription, but that's up to your clinical discretion. And on that prescription, you need to have 3 identifiers. So that obviously needs to be name, typically date of birth and gender are most common ones. You might also put the person's medical record number on there as well. And don't forget to sign them and date them, because if you do, the pharmacy will send them back to you and your patient will be really frustrated with you. I've been there. Oh, and also make sure you note how many prescriptions are on this form. You'll notice on the middle, the bottom third of this prescription, there's it says prescription is void if the number of drugs prescribed is not noted, and you need to check one of those boxes, 1, 2, or 3. That's also a cross check from somebody to keep somebody from adding another prescription to a partially filled out prescription form. And you'll notice that I put a line through my unused section of the form so that the person cannot add another prescription to this list. So there's a little closer up. So that's with 2 prescriptions on the same form. So one for fluoxetine and one for Adderall. So let's talk about how to engage people in being interested in medications. So when we talk about medications, you got to think about that this is like an old-fashioned balance scale. And on one side is the perception of benefit from the patient. When I say perceived, I mean the patient's perception of benefit, not yours, but the patient's. And the patient's perception of the costs. When I talk about costs, I'm talking about all the associated costs with that, taking that medication. The actual monetary cost of it, but also side effects, how much time it takes up, things like stigma. Does the person feel ashamed of taking that medication? If the benefit outweighs the cost, the person's likely to be interested in taking the medication and will likely remain adherent. As soon as the balance tips in the other direction, so even if we think that the person is getting lots of benefit from this medication, but the patient only sees the costs, they're going to lose interest in taking that medication and they're likely to stop. So, a great example of this might be a patient with a psychotic illness such as schizophrenia, that we, the clinician, and maybe the family, sees a lot of improvement. We see that they're not responding to internal stimuli so much. They don't seem so withdrawn. But all the patient notices is that they're shaky and they've gained 15 pounds. And frankly, the voices weren't really bothering that much anyways. So in that person's estimation, all they've got is cost. So does that person stop taking the medication? Yeah, probably they do. So part of our process is to have a conversation about these risks and benefits, and don't just assume because we see benefit that the patient must be seeing it as well. So when we're following up with that patient who started a medication, it's important to assess issues around medication interest and adherence. And you want to do this artfully. This is part of the art of what we talked about earlier. And one of the ways that you do that is to attenuate shame whenever possible. And what does that mean? So, what that means is that you make it okay for the person to say, yes, I am not taking the medication sometimes. So, a common way that I might do that is I say, it's not uncommon for people to miss doses. Uh, you know, last time I had to take medication, I missed doses several times. And then I make a gentle assumption. This is a similar technique to what you might see in substance abuse assessment and motivational interviewing. So I might say, so, how many times do you figure you miss taking the medication? Like 3 or 4 times? And the person might say, oh, no, not that much. Maybe once or twice. Now, if I just said, how often do you forget to take the medication? They'd say, oh, I don't, right? Not because people are lying, but because they like us and they don't want to jeopardize their relationship up with us by making us upset or disappointed in them. So you need to make it okay to say, yeah, sometimes I forget to take the medication. And then you have an opportunity to say, well, can you tell me what's happening on those days? And they might say, yeah, that's when I tend to fall asleep on the couch before I actually crawl into bed. I say, well, what if you took the medication with dinner? Would that work? Oh, yeah, I hadn't thought about that. So that's a way that you can engage the patient in some simple problem solving. And then continue to use this shared decision making approach in medication continuation that you did with medication initiation. So I ask questions about, what do you think the pros and cons of this medication are? How would you feel about staying on this medication? And I want to encourage you to just throw out a term in your vocabulary that might be there already, and that's non-compliant. There's so much. I have so many problems with the word non-compliant, largely because of the power differential that it implies. By saying that somebody is non-compliant implies that I have the power to make decisions for that person, and I generally don't see myself in that role. I see myself as an advisor, as a consultant, but not somebody who's here to tell somebody what to do. And I'm really about trying to level the power relationship between myself and my patient, not to increase the difference between myself and the patient. So try and just get rid of that term non-compliant. It still gets used, and I would love to see it go away. So just a real brief little diversion into how did we get this information that we have about these medications. I like this picture from this was the Science March a couple of years ago. So when we talk about drug development, this is just a brief aside. You'll sometimes hear somebody say that this drug is in late phase 3. Well, what does that mean? So this is the process, starting from left to right, of how a drug gets to the market. So, oftentimes by the time a drug gets to the market, it's been in study for 10, 15 years. Sometimes it takes a long time to get a molecule from inception into your hand. And so that starts with these preclinical lab and animal studies, and then we go into phase 1. Now, phase 1 just starts to give us information about how does the drug travel around the body. It really doesn't tell us much about the effectiveness of the drug. That comes in phase 2. Now, phase 2 studies are usually small, kind of proof of concept studies, looking for an early clinical effect. And then phase 3 is required, the FDA requires 2 large, well-designed phase 3 studies. Now, by well-designed, it means that it has to be a large enough study to show a significant, in fact, a significant improvement over placebo. So that often can require 200, 300, 400 patients, and this can take several years. It's only after those phase 3 studies are in and the data is reported to the FDA that the FDA will then approve what's known as a label for the drug. Now, the label on the drug says that what it's indicated for, so what disease state it's used for, and in what dosing range. That dosing range is usually determined by the studies that were done. So if a drug, so let's take a medication like fluoxetine. Fluoxetine, Prozac, was studied in doses between 10 and 80 milligrams. So it's real common that we use higher than 80 milligrams, particularly in the treatment of, say, something like OCD. That's known as an off-label dose. Now, off-label use of drugs or off-label dose of drugs is usually considered acceptable if it's a common practice in your line of work. So there isn't a rule book that says, yes, you may do this. It's more, is this, if 10 of your peers were asked in a courtroom, is this a reasonable and common way that you practice? And if everyone said, yeah, we use trazodone, for example. So trazodone, an old antidepressant, not indicated for sleep, but used very commonly for sleep in an off-label capacity. I would say the vast majority of medical providers and advanced practice nurses would say, yeah, I use trazodone all the time for insomnia, even though it's not a labeled use of that drug. That's a very common use of it. So it's good when you're going off-label to check in with your supervisor, check your standardized procedures, make sure that there's language in there about off-label use, and document that you had a conversation with the patient that, yeah, trazodone was an old antidepressant that made most people too sleepy for it to be very effective as an antidepressant, but it turns out even low doses of that medication are very useful for sleep. So we use it in an off-label capacity. And I would put a brief note in my chart indicating that I had that conversation with the patient. So I also want to just talk briefly about the difference between clinical significance and statistical significance. And I apologize, this is kind of a busy slide. Now, statistical significance, all that tells us is that this change that occurred by taking the drug did not happen by chance. Now, that difference that is a statistical difference may not be that clinically important. So it may only improve the so for example, an antidepressant might improve the PHQ score. It might lower the PHQ score by 1 point. And in the statistical analysis, it turns out that that difference between so when comparing it to a placebo, for example, so placebo group, they were the average PHQ in the placebo group was 15. The average PHQ score in the antidepressant group was 14. And in the statistical magical analysis, it turns out that that difference of 1 point is not by chance. But clinically, we know that the difference between a 15 and a 14 is not very significant. So you'll often see this term p-value, which p stands for probability. And this is the convention of this is that the idea of a p-value of 0.05 or less is a convention. So if it's 0.05, it means that there's a 1 in 20 chance, a 5% chance that this finding is by chance. And this is a totally arbitrary cutoff. But you'll often see p-values trumped out as being much smaller than 0.05 as a way of conveying that this was a statistically significant finding. Now, clinical significance is more interesting to us as clinicians because the question here is what's the likelihood this is going to help our patient? And there's a few common measures of clinical significance. These are not the only ones. The most common one is the Cohen's d, and this is a measure of what's known as effect size. Now, in Cohen's d, I'm not going to get into the math of how we calculate these. I'll leave that for your statistics classes. But the general convention is that a Cohen's d of a 0.2 or 0.3 is considered a small effect size, 0.5 is medium effect size, and 0.8 is a very large effect size. Another common way of conveying effect size is an odds ratio, usually accompanied with something called a confidence interval. So this is usually abbreviated as OR. And an OR of 1 is the null. So an OR of 1 means that there was no difference between the treatment group and the placebo group. An odds ratio of 2 means that the active group was twice as likely to have an effect than the placebo. Conversely, an odds ratio of 0.5 means the drug is less. So anything less than 1 means that the treatment group was less likely to get better than the placebo. And the confidence interval gives you an idea of how wide the range of findings was. So the tighter a confidence interval is, the more confident you can be in that odds ratio being accurate. If the confidence interval is very wide, then there's a lot more noise in that assessment, and you can't put as much confidence in that odds ratio. Another useful way of looking at effect size is the number needed to treat. And conceptually, the idea is that number needed to treat tells you how many people would you need to treat with that condition, with this drug, in order to get the effect that you're looking for. So obviously, if you have an NNT of 5, which is, by the way, a pretty good NNT, it's not like patient 1 is going to get 100% better and patient 2, 3, 4, and 5 are going to get 0% better. Obviously, the benefit is spread somewhat across the patient pool. But the idea that the concept is that a smaller NNT means that the treatment is more powerful and more likely to help your patient than a treatment with a large NNT. So that's our section on starting a medication. And in our next section, we're going to talk about pharmacokinetics. So stay tuned.